Hello, I'm Dr. Damien Lafferty, a surgical podiatrist. Today, I want to talk about Baxter's nerve entrapment. This follows on from last week's discussion about plantar fasciosis. Baxter's nerve entrapment is a commonly missed cause of heel pain. It is very often mistaken for plantar fasciitis. Many patients are referred to me with chronic plantar fasciitis, but what they actually have is plantar fasciosis, with or without Baxter's nerve entrapment. Baxter's nerve is the first branch of the lateral plantar nerve. It comes from the posterior tibial nerve. As it travels through the foot, it passes deep to the abductor hallucis muscle along the medial heel near the plantar fascia between deeper foot muscles. This nerve supplies motor function to the abductor digiti minimi, sensation to the medial heel bone. Here's the key difference. Plantar fasciitis or fasciosis is mechanical and degenerative. Baxter's nerve entrapment is neuropathic. That means the pain comes from nerve compression, not inflammation of the fascia. The nerve is vulnerable where it bends sharply under the abductor hallucis, or where scar tissue and fibrosis develop near the plantar fascia. Common contributing factors include overpronation, chronic plantar fasciosis, heel spurs or bony overgrowth, previous foot surgery, repetitive strain, or poor footwear. Over time, this leads to nerve injury, which produces burning, sharp, or electric pain. Clinically, patients often report pain on the plantar medial heel, pain that worsens later in the day, pain with prolonged standing. This is different from plantar fasciitis, which is usually worst with the first steps in the morning. Other key features include burning or tingling sensations, local tenderness just in front of the heel bone, pain with medial heel compression. In long-standing cases, weakness of the small toe muscle. Importantly, Baxter's nerve entrapment often coexists with plantar fasciosis, creating a mixed mechanical and neuropathic pain picture.
Diagnosis is primarily clinical. Ultrasound is my preferred investigation. I'm very passionate about using high-resolution ultrasound. In our practice, we have an ultrasonographer on site, and all images are reviewed by a radiologist. This allows us to identify fascia thickening, nerve compression and guide injections accurately. Clinical palpation is also critical. I apply pressure to the abductor hallucis muscle, not the plantar fascia, and carefully watch the patient's response. This palpation is medial and off the main weight-bearing surface. MRI can also be useful, particularly to rule out bone marrow edema or calcaneal stress fractures. These are important differential diagnoses, which I'll cover in future talks. EMG studies can confirm nerve involvement, but in my experience, they are often unreliable and usually unnecessary. Treatment starts conservatively and focuses on reducing nerve compression. This may include orthotics to reduce pronation. However, very uncomfortable orthotics can be a red flag as they may worsen nerve compression. Targeted physiotherapy for foot posture, neural mobilization exercises, shockwave therapy if fasciosis is present, used cautiously as it can irritate the nerve. My most effective treatment is ultrasound-guided hydrodissection. This involves local anesthetic saline corticosteroid, sometimes followed by prolotherapy or PRP. Most patients I see have already tried and failed other treatments. If symptoms persist despite conservative care, surgical decompression may be considered. This can involve releasing the abductor hallucis fascia, removing fibrotic tissue or large heel spurs. Occasionally combining this with partial plantar fascia release. Surgical outcomes are generally good, with 70 to 90% improvement reported. That said, I now rarely perform surgery because hydrodissection works so well. In summary, Baxter's nerve entrapment is a neuropathic cause of heel pain that is frequently mistaken for plantar fasciitis. It results from nerve compression near the medial heel. Diagnosis is clinical, supported by imaging. Treatment focuses on offloading, posture correction, and targeted nerve decompression. Recognizing this condition early prevents repeated treatments for fasciitis that never truly resolves.